Today we are talking about the bronchiectasis. This is the normal airway. This is the airway with bronchiectasis. Normal airway. This is the there is the normal airway wall, and in bronchiectasis there is the abnormal infiltration of the mucus in the lumen of the bronchi, where leading to the widened airway and scarred and thickened airway wall. So basically bronchiectasis, which is a disorder characterized by the irreversible permanent abnormal dilation of the bronchi and bronchioles, which is caused by the destruction of the smooth muscle and elastic supporting tissue resulting from chronic necrotizing infection. It may be diffuse generalized and focal localized. In diffuse generalized, which is also known as the non-obstructive bronchiectasis, it is post-inflammatory, and focal and localized, which is obstructive bronchiectasis. So now talking about the predisposing factor. Under predisposing factors, there is bronchial obstruction, which is due to tumors, foreign bodies, mucus plug, and another one is congenital or hereditary condition like genetic causes like cystic fibrosis, immunodeficiency state, Cardinger syndrome, or ciliary dyskinesia. Now talking about the infections like bacteria like Staphylococcus aureus, Pseudomonas, Haemophilus influenzae, Mycobacterium tuberculosis, rising or suppurative pneumonia, like viruses like influenza viruses, fungi like Aspergillus species. There is also a post-infective childhood pneumonia. Now talking about the pathogenesis. While talking about the pathogenesis, there is the two way. One is obstruction and another one is the necrotizing infection. In obstruction, there is the impaired mucociliary clearance, which increases the pooling of the secretion, leading to the superimposed infection and eventually leading to the inflammation of the bronchial wall. So, if inflammation of the bronchial, if there is the inflammation of the bronchial wall, there is a destruction of the wall, like smooth muscle of and elastic tissue, and increased distension of the damaged wall. In necrotizing infection, there is inflammation of the bronchial wall, which leading to the inflammation of the bronchial wall, leading to the peribronchial fibrosis or necrosis, which eventually leading to the destruction of the wall and increased distension of the damaged wall, leading to the permanent dilation of the bronchi and bronchioles, which cause bronchiectasis. That is. Now talking about the morphology, there is gross and microscopic. In gross, lungs, but there is the bilateral involvement of the lower lobes, which is also distal bronchi and bronchioles are involved. In cross section, mucopurulent secretion in the distended airway and bronchi appears cystic. In microscopic, bronchi and bronchioles, there is the inflammatory exudates within the wall, desquamation of the lining epithelium within the extensive area of the ulceration, necrotizing ulceration may from long abscess. In chronic phase, fibrosis of the bronchial and bronchiolar wall. So, let's talk about the clinical feature in bronchiectasis. There is a severe persistent productive cough, expectoration of the copious amount of the foul smelling mucopurulent sputum, and there is hemoptysis occasionally. Now talking about the complication, obstructive ventilatory insufficiency, which leading to the pulmonary hypertension and eventually leading to the core pulmonary, long abscess, metastatic brain abscesses. Already we talked about the microscopic feature of the bronchiectasis. There is the microscopic view of the bronchiectasis. Now talking about the management, goals are control infection, improve clearance, and prevent complication. For airway clearance technique, here is the mnemonics POST, POST post. P for postural discharge, O for oscillatory device, S for steam inhalation, and T for chest physiotherapy. We use antibiotics, which is based on the sputum culture. Here is the long-term macrolide, which are sometimes used. Now, we also use the bronchodilators if ear flow obstruction present, and also vaccination, influenza and pneumococcal. Treat underlying causes, ABPA, CF, and immunodeficiency. For ABPA, steroid and antifungals, CF for specialized care, and immunodeficiency for IVIG. In surgery, indications are localized disease, massive hemoptysis, failed medical therapy. So procedure is lobectomy. Thank you.